Then I want to jump, okay? I want to jump to thrombocytopathies. So that means level of the platelets is normal, but something, but they malfunction. There's something wrong with them. They're produced in the wrong way. There's something wrong with them. And basically, if we talk about the inherited causes, so thrombocytopathy, okay, pathia, so inherited. And that's why I was telling you about the receptors at the beginning of the lecture, because what about the GPIIb receptor? What does it do? It's important for what? We talked about it. Very good. And it's adhesion, isn't it? Adhesion. So this is this is the receptor you use to glue the thrombocytes to the vessel wall. Okay. And there's an inherited mutation of this receptor, and it's called Bernard-Soulier. Who's French over here? Or who speaks French? Can you pronounce it? Soulier?
Bernard Soulier.
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 Soulier. Okay, I will. Soulier. Bernard Soulier. So it's rare, of course, but you can. It's in the test. It's rare, but sometimes if you write a test, it's in a test. So for medical students, it's questioned sometimes a lot. So remember, this is a mutation of the GP1D. But anyways, remember it's a mutation of the adhesion. And typically, if you do a blood smear, the thrombocytes are bigger. They're typically bigger, but this is a comment, not important comment, if you will. Another mutation is which one? And we talked about the receptor again, and that's why we talked about it. GP2B, very good, 3A. So if this one is mutated, we call it Glanzmann. So this is it German over here? No. You're German. In front? No. Who's German? Can you say Glanzmann? That's going to be simple. Glanzmann. Glanzmann. And old term is thrombocytopathy. But it means thrombocytopathy. It's a synonym. Thrombocytopathy, old term. Glanzmann was the one who described it, I think. So these are two mutations you could maybe remember, but more important is to know what the receptors do, because we're going to still talk about the drugs. We did talk about it during the lecture, but they're rare, okay? But there's another disease which you beautifully can put under thrombocytopathy, but itself, it has nothing to do with broken receptors. Everything is fine with these cells. But still, there is a thrombocytopathy. They're not able to stick to the wall. And guess which disease it is? And this is a common disease, because 1% at least has it. It's von Willebrand. And von Willebrand, that sounds very German. Von Willebrand. Who's German over here? It sounds Dutch. Really sounds Dutch. Von. That would be fun. Van. No? You're Dutch?
No, I'm not Dutch. I was just guessing.
You're right. But I heard it was. But you know what? Obviously, this German name or Dutch, this guy was Finnish. Would you believe? Who's Finnish over here? We don't. You're Finnish. He was Finnish. It's a Finnish doctor, von Willebrand. And actually, I was checking it out. He was a Swedish-speaking Finnish. Okay. So von Willebrand is a Finnish guy. Okay. So Finnish guy. He was the one first described it. Of course, in Finland and their islands, the families stick together on the island. So it's nice to, like now in whatever the island, if you want to follow the genetic disorders, it's always nice. I mean, before planes and boats and whatever, it was, they were stuck in so everyone was bleeding on the island, I guess. So that's how they discovered von Willebrand's disease. And there are more types. 1 and 2 are the most important one. But guess who is more prone for von Willebrands, men or women? How is it von Willebrand? Because typically, if you see that someone has von Willebrand, it's a woman. But can you tell me why this is confusing a bit? Why? Because what is about von Willebrands? You have lower levels of von Willebrand's factor. So your cells, although you have a normal amount of platelets, they are not as well sticking to each other and to the cell. So there's a malfunction. So you have a disorder of primary homeostasis. Can you have a disorder of secondary homeostasis as well?
Mm-hmm.
Why?
Hemophilia? Or?
Not hemophilia. No, with von Willebrand.
Oh, I don't know.
Well, because von Willebrand is protecting factor VIII. So you were very near the hemophilia. Remember, factor VIII needs for its life to stay for some time in blood, it needs protection of von Willebrand. If you have decreased von Willebrand, you're going to have decreased factor VIII. So you were very, very near, although it's not the hemophilia itself as a disease, but you were right, it's the same as hemophilia A, light, very, very light. You will have decreased levels of factor VIII. That's why you're going to have prolonged PTT times, okay? And I realized that I maybe didn't tell you. I don't know, but the group before said they didn't hear it, so I forgot to tell you during the lecture. You know the mnemonic, which is pretty cool. PT and PTT. If you're still not able to remember what is like, as that the PT is the block or checking the times of the extrinsic tenase, and PTT the intrinsic tenase. So basically PT, the extrinsic pathway. So extrinsic, like out, yeah. T, tennis. Where do you play tennis normally? Outside. So it's the outer cascade, okay? Outside. T, 1T, tennis. PTT, table tennis. Where do you play table tennis? Inside, okay? So intrinsic pathway. So you can 1T outside, 2 T's inside, okay? Very simple. And with factor VIII, remember I told you factor VIII, 9, 11, those all aim on the intrinsic pathway. So in von Willebrand's disease, if you have decreased levels of von Willebrand's, you're going to have also decreased levels of factor VIII, which is an important cofactor of the intrinsic tenase, and that's why PTT can be prolonged, okay? But in more severe cases. So, but most of the von Willebrand's diseases are light. So basically, you don't know that you're having von Willebrand's. At the moment, if you take aspirin sometimes, so you start to bleed out of the nose, or you can have some petechias, whatever you start. So basically, you don't know. But why we know more about women that they have it? Because they bleed every month. And if they have a severe menstruation, then someone thinks, oh, maybe she has a von Willebrand. They test for it, and then they will find she has a. Or sometimes women give birth. And typically after or during the birth, they can severely bleed, and that's so you're going to find out that they have von Willebrand. But the message is, how is it genetically? How is it propagating? Von Willebrand is autosomally dominant, okay? So it doesn't matter. It's 1-to-1 men and women, but only that women bleed more, and we know more about women's von Willebrands, but it's 1-to-1, men and women, okay? Yeah? So remember this. And von Willebrand. So if there are light decreases, you don't do anything, and that's most of the cases. So you tell them what? Don't take aspirin anymore, okay? You're protected enough from thrombophilic state, so don't take that. Maybe it's advantage in a way, who knows? Okay? If it's more severe and they bleed, and really bleed, what can you do? We talked about one drug you can give them that squeezes your endothelium. Remember, what is that?
No.
It's desmopressin. Desmopressin, what is desmopressin? Desmopressin is an analog of ADH. Very good. So, and basically, we use desmopressin for diabetes insipidus. Okay, but that's in continuous doses or whatever. But in case you want to help someone to boost up their von Willebrands, you can give him a 1 dose of desmopressin. It squeezes the endothelial cells and whatever, and you're going to have a peak of von Willebrands. Okay, and you can do it like once, twice, but then you have to stop for a few days because the storages are out. So then, of course, endothelial cells sometimes they need some time to produce it again. But you can, if there is a severe bleed, you can give them a dose of desmopressin and it will help. Okay?
If you know a woman has von Willebrand and she is going into labor, and do you do anything to prevent?
Well, it depends how severe it is. I don't know what the gynecologists or obstetricians do because I think they wait if it's going to be severe or not. Well, okay, there's some protection, I guess, but normally it's not as severe. And typically, important is patient's history in this case, or family history. If a girl bleeds and then her mother bleeded, it could be von Willebrand. That's what you should think of. And moreover, for diagnosis, there's one more test you can do. I don't know if someone could ask for it. Maybe remember ristocetin test. Ristocetin is an antibiotic, but we also find out that it very much simulates the, let's say, the endothelial wall. So in vitro, if you put thrombocytes and ristocetin, they should be activated. If they're not activated, there's not enough of von Willebrand. So ristocetin test is a test for von Willebrand's disease. Okay, so you can use that. But in cases they even bleed more and the desmopressin is not working, what can you give? And actually, you just give von Willebrands in a package with factor VIII. So you give them the same thing you are normally giving to people with, or boys with, hemophilia. Okay, so they're getting just the same drug. Okay, because typically, if you're for hemophilia A, for hemophilia A, you're giving typically combination of factor VIII and von Willebrand's. Okay, so you can give them this. So that's von Willebrand's disease. In most cases, you just live with it and nothing. You bleed more from the nose and that's it. Okay. In severe cases, at the end, you're gonna get supplementation of factor VIII and von Willebrand's. Okay, so those were inherited diseases, and most important out of them is von Willebrand's disease. Okay, over here. But if we get to acquired ones, so remember again, nasty alcohol. Alcohol and let's say hemostasis is like a synonym, like impaired hemostasis, because alcohol will cause what? Decreased levels of thrombocytes, impaired thrombocytes, and what else? Cirrhosis, so all of your factors will be down. So remember, alcoholics, they always bleed and etc. So they have problems with this. So alcohol, obviously. What else? Maybe I already told you. Remember uremia. Every time you are failing with kidneys, don't forget, if you're chronically failing, you're going to have decreased erythrocyte because you don't have enough of erythropoietin, etc. But also, with uremia you have too much of urea in your bloodstream, and this urea packs the thrombocytes and impairs their function. So they have thrombocytopathy, the people with failing kidneys. And also remember penicillin. If someone is on penicillin at the moment, then penicillin also somehow packs the thrombocytes and they can bleed a bit, because it impairs their function. So this is sort of with the penicillin, it's a byproduct. But what about the drugs aiming specifically for thrombocytes and let's say it's a wanted thrombocytopathy because you want to prevent clotting, and especially in this case you want to prevent arterial clotting. Okay, so what are they? First, aspirin, of course. So aspirin, what does it do? Blocks COX-1, we talked about it, decreases thromboxane A2, and you block activation of thrombocytes. Okay, so you give aspirin when? Wherever there is a something with arterial wall, and whenever there's something with stroke or MI, of course. MI, mostly heart. Think of heart. Aspirin, heart. But for strokes, you can give aspirin as well. You give it. They give it. If you have a thrombus at the cerebri media, you give aspirin. Okay? But, what are the drugs?
Aspirin?
No, wait. We are talking about thrombocytes. So, and I told you again another receptor during the lecture, and that was the P2Y12. And P2Y12 receptor does what? It's again activation through ADP. And what drug blocks this? It's the clopidogrel. So, and in other words, Flavix, that's the same. So this blocks this receptor, and again, you block activation, okay? And typically, if someone has a severe MI or whatever, MI, typically cardiologists give combination of aspirin and clopidogrel, these together. But, listen now, if you have a stroke, you give only aspirin. There was a study and more studies, and with the clopidogrel to it, and I mean, in case of stroke, I mean, of course, ischemic stroke. You know, the most common causes ischemic of the stroke. The 80% of strokes are ischemic strokes. And in this case, you give only aspirin because clopidogrel could invert it to bleeding even. So that's pretty dangerous. So watch out. If you're taking care of a stroke, you can give aspirin. Don't give combination of these two. But for heart, you give combination. There's a difference. And there's one more drug, and again, receptor, and it blocks 2B3A receptor. So this is a blockage of what? Of aggregation. And what is the name of the drug? Abciximab. Very good. Abciximab. And this is it's a fragment of a immunoglobulin, and they're aiming for these receptors. And that's why they're blocking the aggregation. Okay? Again, the cardiologists, they typically give, for example, combination of aspirin and clopidogrel, or aspirin and abciximab, depends. Okay? I think abciximab is still pretty expensive, so rather Plavix. Okay? So, but this is what they play. So this was a really aimed thrombocytopathy, but still remember, like a general, like a common sense thing, which you should remember. Every time your bone marrow is producing something in terms of myelodysplastic syndromes, myeloproliferative neoplasm, every time your bone marrow is producing something in too big amounts, they also produce defective cells. And typically, this is what you see in, for example, polycythemia vera. Of course, the main increases of erythrocytes, but there can be also increase of thrombocytes. But typically, they're not made as well. They're defective and they have a thrombocytopathy. Okay, so they can bleed, although there are, for example, increased levels of thrombocytes. Okay, so every time there's overproduction and the bone marrow runs like hell, it makes bad thrombocytes. So any of these diseases and let's say proliferative diseases, you can see thrombocytopathy to it. Okay, so those were. Over here we end with the primary hemostasis disorders. So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.